Okay, thank you. I'd like to thank SAGE's program committee and the chairs of the session for the opportunity. I have no disclosures. I guess just going back, the title of the talk is I Can't Get the Critical View of Safety, Now What? So hopefully by now we all have a good understanding of what the critical view is. I won't belabor this, and hopefully we know what it should look like. So let's get right into you can't get the critical view. And I think it's important to talk about or think about why that might be. And I think about this conceptually with sort of three different domains. First of which is any sort of anatomic issues. We've touched on a lot of this already, but obviously very important to review preoperative imaging that you might have, anatomic variants. A few things have already been pointed out, but a short cystic duct or a narrow common bile duct can both be confusing in terms of the biliary anatomy. Of course, accessory or replaced structures can confuse the picture as well. One thing that I find helpful at times for vascular anatomy, if it's a little confusing, is to mobilize a cystic artery way high up on the gallbladder, so unequivocally it's the cystic artery and not a high-riding right hepatic. Of course, closed node is also commonly a landmark that can be of help, but sometimes not practical. Inflammation is the second category. Obviously, severe inflammations, very commonly what we refer to with a difficult gallbladder due to severe cholecystitis or a patient who has a delayed presentation. They had pain for a few days prior to coming to the emergency room. In some cases, trying to mobilize that lateral posterior peritoneum can help to provide a little more freedom for retraction of the infundibulum. And of course, obliterated cystic duct or severe gangrene can cause a lot of difficulty as well. And then the third sort of category is inadequate exposure. General things like body habitus, morbid obesity, but also specifically if you're not retracting correctly, and we've already had a couple speakers allude to this, but you really should be retracting the infundibulum down and away towards the right lower quadrant. And what that does is it triangulates so that the cystic duct is perpendicular rather than parallel to the common duct. Sometimes the gallbladder is severely distended. You can't grasp it well, so decompressing with a lap needle is sometimes helpful. If you have a large stone at the infundibulum, sometimes it's difficult to grasp as well, so you can try to milk it away or just use an open, a blunt tip grasper with an open jaw to sort of brace it to give you that retraction. Sometimes the gallbladder is really intrahepatic or the patient has a low costal margin, which again makes things difficult, but try to use patient positioning to your advantage. Dense, severe adhesions can, of course, limit your exposure. Sometimes you can barely see even a tiny portion of the gallbladder due to the adhesions. And we've already alluded to Rouvier's sulcus, but your dissection should be above that to stay in a safe zone. So can we predict a difficult gallbladder in the preoperative setting? This is one study of several that identified several factors based on a logistic regression model, and those are elevated CRP, an impacted gallstone on preoperative imaging, and prolonged symptom duration prior to operation. And what they found with this scoring system is that the higher the score, the lower the likelihood of being able to achieve a critical view of safety. So the remainder of the talk is really going to be what do we do about this since we've deemed and declared that we can't get the critical view safely. And I would just want to present this in the context of the overall sort of SAGE's initiative of creating a culture of safe cholecystectomy. There was a SAGE's Delphi consensus publication from a few years back that identified these principles. And of course, point number 5 is going to be basically the rest of the talk, but that's just one aspect of creating this culture of safe cholecystectomy. So should I bail? What are the things that you might find intraoperatively that may make you, take pause or reconsider an alternate procedure, specifically because trying to force a critical view may actually be dangerous. And those things are listed here. Again, severe fibrosis and scarring, specifically at the hepatocystic triangle. A really contracted gallbladder can be very difficult to dissect. Gangrene, perforation, some advanced infectious etiologies, cholecystoduodenal or colonic fistulas, Maritzi syndrome, cirrhosis, and portal hypertension. These are all things that can really make the gallbladder quite difficult. So what are the options? And so we've started to list some of these out. And you got to remember that gallstone disease is a benign disease, and you have to weigh the risks, or I guess the benefits of the proposed procedure you're going to do against the risk of a bile duct injury. So, the first option is to just not do anything, which is always on the table, back out, treat the patient non-operatively, antibiotics, maybe a percutaneous cholecystostomy tube. Calling for help is always a good idea. Consideration of transfer to a tertiary facility that may have more advanced expertise in certain situations. Cholecystostomy tube is an option, definitely for gangrenous or gallbladder that you can barely visualize the fundus, or a patient who's too critically ill to tolerate a prolonged operation. Conversion to open is always an option and has been sort of the traditional answer for these difficult cases, but one thing I'll point out is that converting to open doesn't make it a conversion to an easier operation. Our Japanese colleagues have proposed this idea of containing the dissection within the inner subserosal layer, which may or may not be a practical solution in certain advanced inflammatory conditions. And of course, liberal use of cholangiography, especially in high-risk patients. Specifically for surgical procedures that we can do as sort of alternative or bailout options, fundectomy, basically just excising the fundus if that's all you can get to, or due to severe inflammation or gangrene. Excise the fundus, extract the stones, and drain and live to fight another day. Fundus first is a common approach, aka dome down or top down. This has certain advantages. You're going from known to unknown as you go antegrade towards the critical structures. And sometimes as you do that, you can reestablish normal anatomy, but it's not foolproof. Most of us, for our standard lap chole, will do a retrograde technique, so you're doing an unfamiliar technique in a very difficult situation with a lot of severe inflammation. And again, you're heading towards the critical structures when you're dissecting, so you have to be very careful. Fundus first specifically has certain challenges in terms of the technical aspects. Sometimes the fundus is hard to grasp, so you may be better off starting in the middle of the body of the gallbladder and then work your way down. Retracting the liver, because now that you're not retracting the fundus up and over the liver, you're actually separating it. You need to have that counter traction on the liver. So, either a blunt tip grasper and you just kind of spread the jaws to distribute the tension, or this author group uses a rolled up piece of gauze for that purpose. You can consider using a more angled scope if the fundus is very floppy and you want to get a better angle. The most recent Tokyo guidelines, published earlier this year, list subtotal cholecystectomy as another bailout option, and of which there are 2 subtypes. But I guess before we go any further with that, I just want to make sure we address the terminology and make sure we're all sort of on the same page. Dr. Strasberg and colleagues published a paper specifically about this a few years back. And it's important that we're all kind of speaking the same terms. So partial cholecystectomy is not something that we use these days. We either say fundectomy for if you're just excising the fundus, and basically otherwise it's a subtotal cholecystectomy, which is removal as much of the gallbladder as is safely possible, simply put. And for that technique, there are 2 subtypes: fenestrating and reconstituting. Fenestrating refers to the lowest portion of the gallbladder, that cuff of gallbladder, not being closed, so you're not recreating a remnant gallbladder, plus or minus closure of the cystic duct orifice on the intraluminal aspect, versus reconstituting, which you do recreate a remnant gallbladder by closing that lowest portion of the gallbladder. Importantly, those terms don't refer to the amount of posterior gallbladder wall that may or may not be attached to the liver. So the subtotal cholecystectomies, the different subtypes, they have advantages and disadvantages. Pro of fenestrating is a lower risk of recurrent biliary events, but has a higher rate of bile leak. In general, for subtotal cholecystectomy, the technique is to start the fundus and open the gallbladder longitudinally, remove the stones. Of course, consider intraoperative cholangiography if there's any concern. Again, you may or may not dissect the posterior wall of the gallbladder, and then either close or not close that lowest cuff of the gallbladder. A lot of surgeons will consider draining these difficult cases as well. So these are just some cartoons illustrating different techniques. The one on the left is describing, serially taking the circumferential thin rims of tissue until you feel like it's no longer safe to do that. On the right, they're demonstrating sort of filleting open the anterior wall, excising that tissue, and then going to about a centimeter above the point where the blunt grasper can no longer pass. So there's a couple meta-analyses that I'll review quickly. The first was by Henneman, 15 studies, 600 patients, median follow-up up to 42 months, mostly for acute cholecystitis. They had a 10% rate of conversion and bile leak. Their bile duct injury rate was 0.16%. Symptomatic stones in about 2% of patients, but due to their follow-up, that may be an underestimate, and a relatively low reintervention rate. Closure of the remnant or cystic duct orifice had less bile leak, need for ERCP, and less recurrent symptoms. And during their lit review, they identified 4 specific surgical techniques from the papers that they reviewed. The first is basically excising the anterior wall, leaving the lowest portion open and just draining. The second is the same thing, but closing that lowest portion of the gallbladder. C and D are actually also dissecting the posterior wall off the liver with or without closure of the stump. This review is a little bit of a mixed picture because in the stump closure, what they referred to as stump closure actually also included intraluminal closure of the cystic duct orifice, which actually would be the fenestrating subtype. The second one is by Elshire, was 30 studies, 1,200 patients, majority lap. Unfortunately, they didn't report any follow-up data. Again, majority were acute cholecystitis in terms of etiology. Stump closure was a variety of different techniques. Outcomes that they measured, bile leak was around 18%, but more often among the group that was left open versus closure of the stump. Bile duct injury of 0.08%. Retained stones, again, potentially underestimated based on the follow-up data, but higher among the open group, and then the need for reintervention is listed. They did a propensity matching with an open cholecystectomy group, and the laparoscopic subtotal group had a better morbidity mortality profile except for a higher bile leak rate. Lastly, this is a retrospective review of specifically subtotal cholecystectomy patients fenestrating versus reconstituting. It was an 8-year study with median follow-up of 6 years, 175 patients. The majority had a fenestrating subtype, and they looked at intraoperative factors and review of operative reports. They saw that unclear anatomy was documented at a higher rate in those that underwent a reconstituting subtype, whereas fibrosis was described more often in those that had a fenestrating. Surgical drainage was also more common in those that had fenestrating. And not surprisingly, reconstituting had a longer OR time because you're sewing that, or you're closing that stump. Short-term outcomes, there was no difference in deep infections, readmission, or reoperation, higher rate of bile leak and wound infection, and length of stay for the fenestrating. Long-term, one last point is that the recurrence of biliary events was lower in the fenestrating, but they actually found a higher rate of completion cholecystectomy. And if you look at the data, the fenestrating had three patients who had recurrent cholecystitis who required that completion cholecystectomy. No difference in patient-reported quality of life outcomes. And I'll conclude with just saying that, fenestrating versus reconstituting, I don't think there's a consensus, but it depends on several factors, including surgeon preference. My suspicion is that fenestrating is being performed more commonly, but again, it's individualized based on the patient factors. And lastly, I'll just conclude with reminding everyone, hopefully everyone's aware of the SAGE's Safe Cholecystectomy program, which sort of identifies 6 core tenets for culture of safety, and the website's listed here. Thanks.